Thank you for being patient. I know it's a long afternoon. I wanted to tell you that when I did this presentation, I should say when I finished the presentation and sent it to Mafus last week, I was proud of myself because I was well ahead of schedule. And then I went to sleep Monday and the new guidelines came out on Tuesday. And I said, okay, I can say it was just too late to change it, or I should try to get it up to date. So some of these slides aren't as beautiful as I would like them to be because Tuesday and Wednesday was a very busy day. But we'll get the information anyway. AFib is an extremely important topic. I spoke earlier about the Watchman. This is, when I began that conversation, I mentioned the incidence of AFib. 6 million Americans have atrial fibrillation, and we will up to about 12 to 15 million in the next between now and 2030. It's a devastating condition that is life-threatening when it occurs because of the massive morbidity that's associated with that. So we're going to talk about the importance of treating these patients, and it's an extremely important issue when it comes to prevention. I do have a disclosure, as I mentioned earlier. I'm a consultant and speaker for Boston Scientific. What are our objectives today? We will review the atrial fibrillation classifications. I will define non-valvular atrial fibrillation, which has been, believe it or not, something that's very confusing for most of us because of the data hasn't been clear on how it's defined. We now have a clear definition based on the new definition in the guidelines from Monday. We'll discuss the role of anticoagulation and some of the challenges with compliance as well as bleeding issues related to therapy. And what are our current challenges when it comes to treating these patients who, as I mentioned, are very common. We will go over the guidelines and talk about prevention ways to prevent atrial fibrillation before it happens. Now, you know that, I know we have a varied audience here, so I just want to quickly point out, when we look at AFib, this rhythm originates in the pulmonary veins, and that's why we're able to do ablation to treat it. We have a couple of wonderful electrophysiologists here in the audience who could talk more about that than I could, but atrial fibrillation is a wonderful, is a targeted pulmonary vein area. You can't see the pulmonary veins here, but as a result of atrial fibrillation, you get these rates that are very rapid in the atrial chambers, 400, 600 beats per minute. And you can see the appendage here is where thrombi can form and lead to significant problems. The guidelines in 2014 by the Heart Rhythm Society, American College of Cardiology, broke atrial fibrillation into 4 categories. The 4 are paroxysmal atrial fibrillation, that's any group that terminates within 7 days, either through our intervention or self-terminates. If it fails to terminate within 7 days, then it's called persistent atrial fibrillation. And then if it's around for 12 months or greater, that would be a long-standing persistent atrial fibrillation, which has a different implication and less likely to cardiovert than persistent atrial fibrillation. And once the physician and the patient together have decided to no longer to try to get back into sinus rhythm, that's permanent atrial fibrillation. It's not the time frame, it's the decision not to try to convert back to sinus rhythm. We don't tend to use the term lone AFib anymore. That's historically those patients who had low risk in terms of cardioembolic stroke and had no evidence of structural heart disease. That term is not used too often anymore. Now, atrial fibrillation is something that when you find it in your patient, you shouldn't ignore it. And one of the reasons is that once it's there, it's there. 90% of the time it's recurrent. And a lot of this is based on looking at pacemaker information, event monitors, et cetera. And many patients don't know they're in it. Up to 95% of patients don't know at times when they're in atrial fibrillation. And 17% of the time, it's very long runs of this rhythm. Silent ischemia is very common. If you look at CT studies and MRIs, up to 42% of patients have silent events. That's about a 2.6 increased risk above those not in atrial fibrillation. So there is a 2.6 fold increased risk of stroke, of silent ischemia in these patients who have atrial fibrillation. Now I'm going to ask a question. I asked this question last year and I speculated as to what the answer should be. So those of you who were here last year, this is a different presentation, but this question is the same question. What best defines non-valvular atrial fibrillation? To cut to the chase, the important point I want to make here is that The answer is AFib in the absence of mechanic rheumatic mitral valve disease. Now that is important because the clinical trials had a very number of patients in the studies. And the reason I'm going to show you this slide, I don't like busy slides, but this is very important. This comes from the guidelines that I mentioned was just published. And what it basically tells us in this study is that the distinction between non-valvular and valvular AFib has confused clinicians. Many of the trials are unclear as to what the inclusion criteria when it comes to valvular atrial fibrillation is. But the Europeans, in their last guidelines, they defined it as I just mentioned to you, that in the absence of mechanical valve disease or moderate or severe mitral stenosis, it's non-valvular atrial fibrillation. Many of the studies, if you look at the DOAC trials, approximately 20% of those patients included those patients with some degree of valvular disease. That's important because for many years, I remember when we first had DOACs, it was difficult to get them approved if the patient had any degree of valvular disease. But now the official diagnosis or definition put forth by this year's guidelines is those patients in the absence of moderate to severe mitral stenosis or mechanical mitral valve disease, that's non-valvular AFib. Now, what are the advantages? I should also point out the guidelines do favor DOACs over warfarin now. They specifically say that DOACs are favored over warfarin. We'll get to why that might be. We know from a clinician standpoint, it's a lot easier from the standpoint we don't have to monitor the INR as we do with warfarin. And that does not come with an increased risk of mortality from bleeding. Certainly a reduction in mortality overall, as I'll show you later. There's the dietary interactions that you typically have with patients that are on warfarin. The drug interactions are not zero because there are seizure medications and others that do interact with DOACs, but not nearly as great as it is with warfarin. We do have to be a bit careful. I find still, even though I've been out a number of years now, there's still dosing errors with DOACs, and it's important to look at the renal function, and you should check liver function also. Again, brought up in the guidelines, important to consider those variables. And remember, when patients are not using the drug, because the half-life is so much shorter than warfarin, that you can get into trouble a lot sooner than you would with patients, for instance, who miss a dose of Coumadin or warfarin. I mentioned already the incidence is quite high. About 20 to 30% of all strokes are AFib related. These strokes come at a big loss, such as aphasia, and 2 out of 10 patients that have AFib related stroke develop aphasia. Many people can't go back to work. Of those working, only 2 out of 10 go back after they've had a stroke from AFib. So it's serious. And my mom I was mentioning earlier, had a large stroke about a year ago for newly diagnosed AFib, and she's aphasic from that, and that's a significant change in her lifestyle. Now, is there a simple way to assess? The simple answer is probably no. The best thing that we have is a CHADS VAS score. You may recall historically we used the CHADS 2 score. The CHADS VAS score includes a larger base of patients. One point I want to make for women is that women do have a higher risk of stroke, particularly women over the age of 75, and definitely over 65 also. And the guidelines would indicate that if you have 2 of the other risk factors for CHADS VAS, that is congestive heart failure, hypertension, age over 75, diabetes, or prior stroke or vascular disease, and you're a woman, you're at substantially increased risk. So that is the real point why we include women as a separate category. There's a 30% increased risk of developing a stroke. If you look at all of the major studies that were done several years ago, you'll find that all of them show about the same, where you have about a 33% reduction across CHADS VAS score if you compare warfarin with no warfarin to warfarin. So a significant 2/3 reduction in event rates. I want to point out that the European guidelines took aspirin out of any level of treatment for AFib. The US guidelines retain that option for people with a CHADS VAS score of 1. No other CHADS VAS score should be considered for aspirin. I personally feel that aspirin is useless when it comes to AFib, but I would encourage all of you to get away from its use. I'll show you a slide later where there's still a lot of people using aspirin by itself for the treatment of AFib. Well, do we have ways to decrease it? Do we have effective ways to decrease stroke? The answer is yes. I've already told you that. So if you look at the blocker, the 10A blockers, so the rivaroxabans, the pixabans, et cetera, those direct inhibitors of 10A. You also had the first one was the bigatran, which was the direct thrombin inhibitor. These are the main locations in which we block using the direct, the newer anticoagulants, or I should say the direct oral anticoagulants. We all know that the old mechanism for warfarin was to inhibit 2, 7, 9, and 10, also affects on protein C and protein S. Much more wide range, which probably accounts for the higher rate of bleeding. Remember the differences between the two categories, between warfarin and DOACs, is primarily increased intracranial bleed when it relative to, that is for warfarin relative to the DOACs. If you look at the incidence of intracranial bleed for warfarin, it's somewhere in the range of about 0.5 to 0.7%, so relatively small, but quite devastating. You can cut that in half when you use DOACs. So it may be a small number, but when you're dealing with such a devastating problem, it makes a big difference. These again are the early studies looking at atrial fibrillation, and you can see these are very old studies that proved a substantial benefit with the use of warfarin. Here are the newer studies comparing, this is a meta-analysis of 4 trials comparing DOACs and warfarin, and you can see that there is a benefit for using DOACs compared to warfarin driven by intracranial hemorrhage. And I think this is probably why the guidelines made the decision to favor DOACs over warfarin. So who should be treated? Well, I went into that just a little while ago, but I again want to just emphasize aspirin, in my opinion, you should get away from using it. People with a CHADS VAS score of 2 or greater should be on some therapy, typically anticoagulation, which is our mainstay for the treatment in patients with atrial fibrillation, those that have outlined. This is another controversial issue that we all have to deal with, and this was also brought up recently, just on Monday, in the guidelines. How should we treat patients with renal failure and chronic kidney disease? This is the guidelines. Again, didn't have an opportunity to make it as beautiful as I would like, but we'll go through it quickly. The bottom line is this: if you are going to treat someone on dialysis, your choices are generally warfarin or pixaban. That's the guideline 2B recommendation. If patients are on dialysis, it should be either warfarin or it should be a pixaban. The pixaban is metabolized through the liver, unlike the other direct inhibitors and the other 10A inhibitors. So it's safer, probably the reason why it's safer. There have been studies to verify that it is indeed safer, then it is safe in that setting. Now, if you don't have dialysis patients and their GFR is over 15, the patients then can use the other agents as outlined. If you look at here, creatinine clearance 15 to 30, the bigatran can be adjusted. Rivaroxaban can be adjusted. So you can still use these other agents, but you have to, of course, dose adjust based on the data that, the information that's there. And this is all a recommendation. We have no trials looking at this. I want to make that clear. We have no trials when it comes to exactly looking at dosing in drugs other than the apixaban that I mentioned earlier. Are we doing a good job when it comes to treating our patients who are at risk for stroke? What would you guess is the percentage of patients who are on oral anticoagulants of these numbers? Just someone guess it. 50. Maybe it's gotten better though. So I should say that based on, and I'll come to that next. My slides got mixed up here, but let me just show you one of the issues this is actually one of my patients. I had a routine echo on him. It looked like he had a thrombus on his transthoracic echo, so I did TE, and he has a huge thrombus sitting here in the left atrial appendage, a lot of spontaneous echo contrast in the left atrium. So clearly, it's substantial risk for stroke. He had been non-compliant with his therapy. He became compliant. This actually went away on a repeat study, and he's doing fine. Fortunately, he did not even have a stroke. But the point is, this is what we get. We get this sludge in the left atrial appendage, in the left atrium itself. You get the spontaneous echo contrast. And when you have that, you can understand how serious it can be. If that clot goes from the appendage to the brain, you can imagine what's going to happen, or any other part of the body. It's not going to be a very nice outcome. But when you look at this, the database from this is very sensitive. If you look at this national database, the Pinnacle Registry, this was a study the data was acquired between 2008 and 2012. So what you're going to see here is most of these patients, when treated with anticoagulation, it was with Coumadin, because the Vigatran wasn't approved until around 2012. So only a small percentage of patients were on DOACs. But what you found is at its max, only about 50% of patients were being treated with anticoagulation. 50%. Now, there could be a lot of reasons for that, but this is a large database. This is over 490,000 patients. So this is not a small database. You may say, well, that's because it's Coumadin. Well, that's because it's warfarin. But actually, when you look at DOACs, there's still an issue. So we really have a problem. About 30% of patients on NOACs stop taking the drug in 2 years. So we have a compliance issue, not only with warfarin and getting patients on it, but also in NOACs. There are other studies to confirm that compliance rates are below in patients that are taking DOACs have a very low compliance rate. One of the things that Dr. Schwartz mentioned earlier, the way to figure out if someone's taking a medicine is the Carla pharmacy. And that study looked at pharmacy rates, and of that, greater than 80% of the patients after 1.1 year. Only 47% were greater than 80% compliant after 1.1 years. Then when you look at the clinical trials, the other concern we have is even in the best situation, rivaroxaban, apixaban, dabigatran, all of these major studies, you had a very high discontinuation rate. You're talking from 21% up to 34%, and also significant bleed rates. Now, I want to make a point here. Just because there is a bleed risk when it comes to anticoagulation does not mean you shouldn't anticoagulate. There's a big difference between having a large stroke versus having a GI bleed. If you have a 3%, almost all bleeds related to anticoagulation are GI related or something less serious than a stroke. So I want to make it clear we should always treat our patients who have atrial fibrillation. There are a lot of reasons for stopping the medicines. I'm not going to go through all of them, only to say many of the reasons that patients in the Orbit trial, about 13% were not on anticoagulation, had to do with either bleeding or patient refusal. Now, let's move on to what should be done in post-PCI. This is another thing that always concerns us when it comes to anticoagulation. This, again, new from the guidelines from this week. I'm not going to go through each of these, but I'll give you the overview. You can read this yourself later. In patients who are on triple therapy, so in those that we make the decision, they just had PCI, that they have to be on triple therapy, those patients, you should consider Plavix instead of Effient or Prasugrel or Ticagrelor, because it's less likely to cause bleeding. That's a 2A indication. And the other point that's really important is that, in which I've been doing for a while, in many cases, you can go to just two therapies. That is, just using one of the like P2Y inhibitors in combination with an anticoagulant, and often with Coumadin or a lower dose of rivaroxaban. That's one of the other agents. So the real key here, we're going to start backing off on therapies. Instead of using triple therapy, consider using two therapies right away. The outcomes do not seem to be worse than if you use triple therapy. In fact, we know with triple therapy, bleeding is substantially higher. And the last thing is that if you do use triple therapy, that the recommendation is a 2B indication, so still not fully vetted, that you should stop it after about 4 to 6 weeks, stop the Plavix or stop your P2Y inhibitor. So I think the move is going to be going in the direction of less instead of using triple therapy. Who should we bridge? Again, addressed this past week. And the bottom line is, in patients that have mechanical valves, you should bridge with heparin. Those are the ones that you have a level of evidence C that you should do. And those patients that are on warfarin, you have to weigh the risk versus the benefit. Perhaps using the CHA2DS2-VASc score, and those patients with higher CHA2DS2-VASc score consider bridging, and particularly if they're going to be off of it a long time because of the surgical intervention. When it comes to using DOACs, the recommendation is not to bridge because you come off of the medication for a short time and the benefits of bridging has not been shown. But if it's an extensive operation, you should reverse them. Now, you know we have Praxban. As Tony doesn't like to say sacubitril, I don't want to say adarucizumab. So I'm going to say Praxban, and that's what we use to reverse pradaxin. And then andexanate, which most of us don't have yet, is to block or to reverse the 10A inhibitors. So if you're having a surgery that requires extensive intervention, these should be reversed instead of bridging. Are there other options preventing stroke? I'm just going to briefly mention two. One is that we have now a 2B indication for the atrial clip, which is a surgical intervention, which we do many at our institution, typically in combination with some other surgery, such as valve surgery or bypass surgery. We atrial clip all of our patients who go for surgery. And then, of course, there's a 2B indication now for the Watchman device. So can we prevent atrial fibrillation? This is going to be one of my last slides. The answer is yes. There's clear data that lowering BMI does have an impact on decreasing the incidence of AFib. There's a retrospective study looking at the Mediterranean diet and extra virgin oil that showed some benefit in decreasing AFib. We know that it's closely linked to hypertension and sleep apnea, tobacco avoidance, and of course, diabetic prevention and control. All of these are ways that we can decrease AFib. So in summary, AFib is often asymptomatic and is under-recognized. It's potentially devastating for strokes, but it must be treated in some form or fashion. Very important that we address these issues. DOACs can be used in all appropriate patients in the absence of mechanical valves or mitral stenosis. We have underutilization of therapy, and we should consider the newer approaches to treating atrial fibrillation with devices when we are unable to use our gold standard, which is still anticoagulation. We should focus on prevention also. Thank you.